Very good afternoon, and welcome to our AstraZeneca symposium on precision care medicine in prostate cancer, where we are having a lecture that will be delivered by Professor Noel Clarke from the UK. Professor Clarke is a consultant urological surgeon and a clinician scientist who manages complex urological cancer surgery and undertakes studies in urological cancer through basic translational science and clinical trials. He specializes in secondary and tertiary referrals of complex pelvic and retroperitoneal surgery, dealing with high volume complex cancers of the prostate, testis, kidney, and bladder cancer, in addition to complex abdominal pelvic malignancies. He also leads the GU research group and Fastman prostate cancer research teams at the Christie and University of Manchester Cancer Research Institute. It's one of the largest prostate cancer research groups in the UK. In trials, he is the co-PI of the Stampede and Radicals trial and is also closely allied to other ongoing international studies. He is the joint clinical lead for the National Prostate Cancer Audit in England and Wales and has published over 250 peer-reviewed scientific papers and co-authored 9 book chapters on urological cancer and its management. So without further ado, I'd like to invite all of you to listen to Professor Clarke's talk on applying new evidence to optimize care, precision medicine, in advanced prostate cancer.
I'd like to thank you for the opportunity to speak to you at the Urofair meeting about applying new evidence to optimize care and precision medicine in advanced prostate cancer. My name is Noel Clarke. I'm a consultant urological surgeon at the Christie and Salford Royal Hospitals in Manchester, UK. I'm Professor of Urological Oncology. I have some disclosures. I have various honoraria consultancy, and I'm the co-PI of the Stampede Radicals Patch and Propel trials. Now, what do we mean by advanced prostate cancer? This is a funnel plot. And what you can see here is data from the National Prostate Cancer Audit in England and Wales. We have about 40 to 45,000 cases annually presenting in England. And each dot on this funnel plot represents a specialist NDT throughout England. And what we can see is that when men are first presenting with prostate cancer in this country, about 16% of them have metastatic prostate cancer at first presentation. Well, why is that important? Well, it's important because if you look at this manogram, you can see the proportion of men who present with M1 disease and M0 disease. About 40% of the prostate cancer deaths come from those men who present with metastatic disease at first presentation. So clearly, this is an aggressive form of the disease, and most of these cases will progress to castrate-resistant disease after 2 to 3 years. And amongst these, the sites of metastases are also important. This is a paper we published in the British Journal of Urology International in 2018, looking at the recent SEER data, 17,000 cases of men presenting with prostate cancer, and looking at whether they had bone-only, bone and lymph node disease, other sites, and only non-related non-regional lymph node disease, which you can see in orange at the top of this graph. The difference in survival is quite profound. So if patients have only got lymph node disease, their biology is quite different to those who have bone and lymph node disease or visceral disease, where the prognosis is really not very good. When we look at traditional treatments and the outcomes, in this kind of prostate cancer, this is data from Stampede, which we published in 2015. And it looks at the control arm of the Stampede M1 data set, i.e. men presenting with metastatic disease at first presentation. And if you look at the blue line, that's the failure-free event. You can see that most men treated with ADT alone are failing within 1 year. And you can see the survival in the purple line at the top. In other words, the outcome with traditional therapies with ADT alone is really not very good. By contrast, if you look at this funnel plot again from the National Prostate Cancer Audit in England and Wales, from 42,000 cases, about 14,000 of those are high-risk, clinically localized cases treated either with radical prostatectomy or radiotherapy. And again, each dot represents an MDT in England. Back to the manogram, and you can see that the natural history of these cases is much longer. About 60% of the prostate cancer-related deaths come from this group, but these patients live an awful lot longer than those presenting with primary metastatic disease. And you can see this again in a further publication, which was in JAMA in 2015, looking at the outcomes from men treated with ADT and radiotherapy. In the blue line again, you can see that out of 5 years, about 50% have started to fail biochemically, and the death rate is about 1 in 5. So significant, but very much lower. And if these patients are treated, this is a subset of data from the same paper, looking at N0, M0, and clinical N plus M0. Radiotherapy to the primary makes quite a big difference to these patients. So the primary site really has an influence in how the disease is spreading. The mode of presentation is critically important. So in this group of patients, does systemic therapy with chemotherapy additional to the ADT make a difference? And with this data, which is from the GETO 12 trial conducted in France, this is the 12-year update from the GETO team. And looking at metastasis-free survival, what you can see immediately from this Kaplan-Meier curve is that out of 12 years, there starts to be a difference with a hazard ratio of 0.81 and a modest but significant improvement in survival, but it takes 12 years. So can we justify giving chemotherapy to that group of patients? Well, not at the moment. And this brings me to the next phase of this talk, which is that individual prostate cancers have different genomic characteristics. And this genomic instability can lead to extensive genetic diversity. And within a prostate and within prostate metastases, there are different clones which have different biopotential and can lead to different types of aggressive behavior, whether that's in the primary, whether it's in lymph nodes, whether it's in bone, or combinations. This is a paper we published in 2019 in European Urology Oncology from our Manchester research team. What we did was we took individual prostates that were removed at prostatectomy. We compared the MR scans, and we did sequential genomic analysis of individual cancers sampled within each prostate. So you can see on the left of your screen, the white dots represent the cores taken from the prostates. And on the right of your screen, you can see the different genomic analyses looking at different genomic testers, Oncotype, Prolaris, Decipher, and so on. What's clear from this kind of study is that there's genetic diversity within the prostate, and even within biopsy cores taken from adjacent areas, the gene profile is quite different. And this has implications for how patients are treated. This is a further paper which we published last year from the Stampede trial in JCO Precision Oncology, looking at the genomic profiles of cases who had high and low volume metastatic prostate cancer. And I'll come back to what I mean by high and low volume in a minute. And again, what we can see is that there's really quite a difference. On the left is the genomic profile of these cases. These are all primary presenting prostate cancers. You can look at the P10 burden, which is reasonably similar. But in the table on your right, you can see that there are key genetic differences, particularly in P53, in DDR alterations, in other words, BRCA, ATM, CHEK2, and so on, and differences in other key pathways, such as the Wnt pathway. And this is fundamentally important when considering how to treat patients using precision oncological methods. There are other ways of defining the molecular taxonomy of prostate cancer, and this is a paper from using data from the Cancer Genome Atlas Research Network, published in Cell 2015, where 333 primary prostate cancers were looked at, looking at mutations, copy number alterations, protein expression, and so on. And different subtypes could be identified based on DNA hypermethylation, the androgen receptor pathway, DNA repair defects, and so on. And clearly that has a knock-on effect and significance when considering what treatments are available and how these patients might respond on an individual basis. Again, a further subtype looking at luminal basal prostate cancer subtypes with different prognoses and responses to therapy. So with luminal B, a very much worse prognosis by comparison with basal and luminal A. So what we can conclude from this is that in prostate cancer, clearly one size doesn't fit all. And if you take the snowflake paradigm, where all the snowflakes look roughly the same when you're looking at them with a naked eye, when you start to look at them more closely, there really is quite a difference in each individual one. And that needs to be considered in relation to treating prostate cancer. So let me come to how we might target precisely these high-risk cases according to hormone status, stage and burden, castrate resistance, timing, and so on. Because one of the things which has become mainline now is the genetic and molecular subtyping of disease to assess response. How do we do that? Well, here's one way to do it. Current options for genetic testing in prostate cancer, looking at next-generation sequencing in tumor tissue and circulating DNA profiling. And there are a number of alternatives, and these are private firms largely who've been set up to do next-generation sequencing. And this is becoming cheaper and cheaper and cheaper. And it's of increasing relevance in relation to the BRCA1 and 2 mutations and other homologous recombinant repair defects. So let me come to a series of subtypes where I'll examine how we might apply precision medicine in advanced prostate cancer. And we can look at precision in timing, because that is quite critical. If we look at this table here, which looks at early systemic treatment. So in the upper part of the graph, you have the cases treated in the hormone-naive setting in big trials, Titan, Stampede, Latitude, and so on. And in the lower part, you have cases that were castrate-resistant, and you'll be familiar with these trials. That's 327, Google trials, and so on. And what's immediately apparent is that the hazard ratio is similar, but the survival, which is in the delta on the right-hand side of the graph, is much longer. The average survival in castrate resistance with these agents is between 2.5 and 4.5 months, whereas it's about 15 months or so, and perhaps even longer in the long term with early disease. So treating earlier in the disease process is much more effective. What about applying precision medicine to the choice of drug? Should it be chemotherapy, or should it be a novel hormonal agent? Well, there's very little data on this at the minute. The PEACE-1 trial in Europe is recruited and will report shortly. But this is all we have to go on currently, which is an opportunistic analysis within Stampede, published in Annals of Oncology in 2017, where it was possible to compare abiraterone and docetaxel. Now, this is the scheme of the Stampede trial, and during this period, both the docetaxel and abiraterone arms were recruiting at the same time, and that enabled us to compare these patients. This was not a direct head-to-head comparison, but the cases were recruited under similar circumstances, and you can see that some of them had docetaxel versus ADT as standard of care, and others had ADT plus abiraterone as standard of care. When we look at the key outcome measures, I'm not going through the detail on this, but if we look at failure-free survival, progression-free survival, metastatic progression-free survival, often driven by PSA, we can see that there is a trend to a better outcome with abiraterone. However, when we look at key clinical events, which are skeletal events, cause-specific survival, and overall survival, there really is no difference, that one is the equivalent of the other. And it comes down to what an individual clinician and patient preference is as to what is going to be given in this primary presenting hormone naive or indeed metastatic progression presentation. One thing which is likely to make a difference, and this is a somewhat complicated image, but if you look at this graph, which is disease state by time and treatment in the M0, concentrate on this one, which is the M1 patients. These are the deaths in dark blue, and you can see that they are pretty much equivalent. But the big difference really is in failure-free survival. And what you can see is that in patients treated with docetaxel, their PSA failure rate is much more rapid. And this may drive clinicians and patients to switch treatment much earlier, because PSA is often a trigger for an alteration in treatment if patients start to fail. So at the end of the day, it doesn't make any difference to survival or really critical events, whether it's docetaxel or abiraterone, but the PSA will go up more rapidly if patients are treated with docetaxel by comparison with the anti-androgenic agent. What about precision in localized treatment and the assessment of tumor burden? Again, critically important. We published on this in the Stampede RMH paper in 2018, where we had dichotomized or split the patients according to metastatic burden using charted criteria. And in patients presenting with metastatic disease, we found that in those that had a high metastatic burden, giving radiotherapy to the prostate really made no difference at all. However, if the patients had low metastatic burdens defined by charted criteria, we found that there was an improvement in survival and a bigger improvement in failure-free survival. And this has now become a standard of care. We've got more sophisticated in our analysis of this, so rather than dichotomizing the tumor burden according to Stampede criteria, we've looked at this in relation to a number of bone metastases, 1, 2, 3, 4, and this is a hazard ratio for survival. And you can see that this is a linear effect, that at 3 or fewer bone metastases, there's a clear benefit. This is the equivalence line here, but some patients can get benefit to the primary treatment, but by and large, the cutoff is between 3 and 4 bone metastases on standard bone scanning and CT, and that we see that the failure-free effect is even greater than it is for the survival effect. But this is not the case when we look at targeting systemic therapies looking at risk and burden. In docetaxel, the 2 papers looking at the screen on your left, which is Charted and Stampede, and the 2 first papers looking at novel hormone agents with abiraterone, which was Stampede and Latitude, both published synchronously in the New England Journal in 2017. So the key thing here is that docetaxel with Charted had a volume or a burden restriction, and with Latitude also there was a restriction based on risk. We didn't find that in Stampede, and indeed when we went back and looked at all the data, we published this in 2019 in Annals of Oncology. We took a large number of the patients, centralized all the scans, analyzed them according to Charted and Latitude criteria, and what we found was this, was that looking at overall survival for docetaxel, there really was no difference, whether it was low or high burden, and indeed the low burden patients got an even better response than the high burden patients. So systemic treatment, the burden really doesn't make a difference. We've looked at this with lymph nodes. We're about to publish this, where the lymph node burden is also important, and that, of course, doesn't feature in any of the current risk stratification criteria from other trials. So let's come to this. You're all familiar with a picture like this, which looks at the prostate cancer journey. But I'd like you to focus on this bit, which is the recent shifts in precision medicine, which have occurred around this point and around this point. We've got big changes looking at standard of care in XRT, novel hormone agents given in conjunction with ADT, which becomes standard of care, and also ADT and docetaxel. But we also have a number of other agents, and particularly those agents looking at PARP inhibition in this area here, and I'll talk about this in detail in the next slides. So let's look at precision in genetic subtype and the importance of DNA damage and PARP inhibition, and particularly in castrate-resistant metastatic prostate cancer, which is a different scenario than hormone-naive, as I've hopefully made clear in the early part of this talk. Now, if we look at this, this is a population study from Spain, looking at a prospective cohort study of germline DNA repair mutations on the outcomes of patients with metastatic castrate-resistant prostate cancer. And what this paper showed was that patients who had DDR or homologous recombinant repair defects in BRCA and ATM, CHEK2, had an improved or had a different characteristic progression than in other types of disease. And this somewhat complicated slide is from the olaparib paper study 8, which I'll talk about in detail in a minute. But focus on this bit of the slide, and you can see that these mutations, BRCA2 here, ATM here, CHEK12 here, they can be either germline, in other words, you're born with it, or they can be somatic, in other words, it's within the tumor, but you're not necessarily born with the DDR defect. And that is of importance because of the natural history of these things. Now, this was an important study. This was TOPARP-A, and it was published in the New England Journal of Medicine. And it followed a preliminary exploratory study, which was done in London, looking at DNA repair defects and the effect of olaparib in various cancers. What it showed is that patients with prostate cancer who were given a PARP inhibitor, in this case olaparib, had a much better biomarker positive survival than those who were biomarker negative. And their overall survival, as you can see, is very clearly different. So important, indeed groundbreaking hypothesis-generating study, which is followed by a slightly larger study, called the TOPARP-B study, again published by the same team, but in a wider setting, which screened patients for DDR defects. There were 771 patients screened in this to enter into this study, and there were 92 suitable for the treatment. And you can see that these patients had BRCA2 defects, ATN defects, CHEK12, and a variety of other associated defects. And in the waterfall plot, those patients who had the DDR defects actually got very good responses to olaparib. The next step was the PROFOUND study, which was published in the New England Journal of Medicine in 2020. And you can see from the numbers in the table here that this was a much bigger study. It was divided into two cohorts, cohorts A, and then they were combined to cohorts A and B. Now, what's critical here is that a lot of patients needed to be tested in order to get the required number of patients for the study. That said, what is important is shown on the right here, where you can see that the efficacy of olaparib was much better than other standard of care in red here. Really quite a profound difference, but only in those who have DDR defects. And that's important to consider. So what about this concept that PARP inhibition might be used for all comers? Because clearly testing 4,000 odd patients to get a much smaller number to put in a trial is not necessarily clinically very easy, and indeed may not be a feasibility for many countries. So this is something that was tested out based on laboratory data, which suggested that olaparib and abiraterone in combination might be synergistic and have anti-tumor activity. And we already knew that there was olaparib, indeed PARP inhibition, which blocked the DNA repair pathway and was effective in prostate cancer as well as other cancers. This was tested and published in an initial study looking at a PARP inhibitor called veliparib. This was a phase 2 study, which is published by Maha Hussain, very well-known oncologist from North America. And this study was a negative study in the abiraterone and veliparib group. There really was no difference to those treated with abiraterone alone. And it's not clear why that was negative, but veliparib is not as powerful a PARP inhibitor as some of the others that are available. When we looked at this in a phase 2 study, known as Study 8, which was published in Lancet Oncology in 2018, there were 142 patients in this study, and they were randomized to olaparib and abiraterone versus placebo and abiraterone, taking all comers. In other words, they didn't necessarily have to have a DDR defect, although we did test the DDR status. These are the characteristics of the patients in this trial. You can see that they're pretty much equivalent in all circumstances, performance status, PSAs, and so on, although the PSA was a little different in the combination arm. We tested them retrospectively and classified them for homologous recombinant repair defects, looking at whether they had a DNA HRR mutation in any positive sample, either in tissue or in blood, whether all tests were negative, including the tumor, and then they were truly wild type, and then those patients in whom they were partially characterized. In other words, we had a negative blood or plasma test, but no tumor test material available. And what we could see was that when we compared olaparib and abiraterone in blue with placebo and abiraterone for patients who were definitely DDR mutated, but in the others who were not necessarily DDR mutated, we found that there was an effect of the combination in all comers. And this was the first time this had been shown in this combination type study. There were side effects, and the main side effect was that in patients with olaparib and abiraterone, then there were 7 patients who had serious myocardial problems and only 1 in the abiraterone group. And that was a cause for concern, which is not fully understood, but which has been compensated for in the next phase of the study, which is PROPEL. And this is a large-scale international multi-center study which randomized patients to olaparib and abiraterone versus placebo and abiraterone, but as the first-line treatment as the patients became castrate-resistant. And there was very strict regulation looking at cardiac function, ECOG performance status, and so on. The primary endpoint was radiological progression-free survival, with a key secondary endpoint of overall survival and a variety of other secondary endpoints. This study has recruited and is in follow-up. We hope to report the findings of this in the early part of 2022. What are the differences between PROFOUND and PROPEL? Well, they target distinct but complementary patient populations. So if you look at this study, this graph here, it looks at PROFOUND eligible. Well, they have to have a homologous recombinant repair defect, and then the PROFOUND eligible, whereas patients going into PROPEL don't need to have a homologous recombinant repair defect. And we hope that if PROPEL is positive, then this will open the way for many more patients to receive the combination treatment without necessarily having to go through a lot of testing, a lot of negativity, and increased costs, etc., etc. Of course, there are other studies going on looking at PARP inhibition and novel hormone agents. These are the main ones. If you look at the colored bars across the top, you can see PROPEL to your left. There's the talazoparib study, which is ongoing, the magnitude study from Janssen, and the CASPER study looking at rucaparib, all of which we'll be reporting presently. And this is the sort of timeline where we expect the readout from these trials. So talazoparib started first, PROPEL thereafter, the magnitude and rucaparib studies. And we expect that PROPEL will report as the first study. That timeline suggests 2021. In fact, looking at the data just recently, that has been pulled back. We won't be presenting the data this year. It will almost certainly be in the early part of 2022. But we're hopeful that there will be important data to come. And if the trials are positive, then we may see a complete change in practice in advanced prostate cancer with precision medicine. So the era has changed, the climate has changed, and we can now apply the evidence to optimize the care of our patients using precision medicine. And I'm hopeful that our advanced prostate cancer patients will get benefit from these new agents as and when they arrive for use in our clinics. Thank you very much.
All right. Thank you very much, Professor Clark. That was really a wonderful presentation, very well laid out and illuminating, that has us all brought up to speed on precision care in prostate cancer. Before we move on to the discussion, I'd like to quickly introduce my other panelist, Dr. Tanuja, a very good friend from the Department of Medical Oncology, National Cancer Center, Singapore. She's a consultant in the Department of Medical Oncology, subspecializing in genitourinary, thoracic, head and neck cancers. And she's also a clinical assistant professor at the Duke NUS Graduate Medical School and a clinical lecturer at the Yong Loo School of Medicine. Her research interests are in geriatric oncology and GU cancers. And she was also awarded the European Society of Medical Oncology Fellowship Grant for her research. She's well published in many international journals. So welcome, Tanuja. And
Thanks, KJ.
Welcome back again, Prof. Clark. Thank you. That was really a very great talk. I think that was really interesting for our urologists who are attending this Urofair meeting. And a lot of us have the question of genetic testing. It seems that, it's going to become one of the standards of care that we routinely test patients in terms of the genetics. I just wondered what both of you thought of this, especially Professor Clark. Where do you see this going? Do you think urologists are going to need to be much more conversant with genetic testing? Should we be doing it ourselves? Do you think special training is necessary? What are your thoughts on this?
I think the answer is yes. Urologists will need to become skilled in this area. And it's not just in advanced prostate cancer, it's also in the early stages of diagnosis. What has now become clear is the genetic diversity of certain types of prostate cancer and subtypes in particular. So if one takes the diagnostic elements for prostate cancer, and most urologists are the people doing the diagnoses, then it's important to look at family history. It's important to look for DDR subtypes, particularly groups of patients who have BRCA families and similar types of mutations, because they do behave more aggressively. They present often earlier. One can predict that the patients are going to get problems with the disease, and they may or may not respond as well to radiotherapy or certain types of intervention therapy. And we need to understand that better. And certainly in the late stages of the disease, well, it is going to be important if patients are going to get benefit from newer classes of drugs, and PARP inhibitors are just one of the newer classes of drugs, because it will enable us to target specific groups of patients, much in the same way that breast cancer has gone and often does go 5, even 10 years ahead of prostate cancer.
Yeah, that's really fascinating. Looking through the details of PROfound, there was somatic testing being done as well as germline testing. What are the kind of hurdles that you face in terms of doing these testings? Obviously, you're in an academic center surrounded by a very highly trained multidisciplinary team. For myself, I work with Dr. Tanuja and other medical oncologist colleagues, and we have a geneticist available to do these counseling. But for many of the urologists in the community, they may not have access to geneticists. So, how do you feel about this becoming a routine kind of counseling? Do you think there's a huge difference in counseling for somatic mutations versus germline mutations? how would you advise somebody in the community to approach this?
Yes, thank you. That's a somewhat multi-layered question. When I was a research fellow, PSA was in its infancy. There were very few centres that had the ability to do PSA testing. In our lab, even in a teaching centre, the lab only ran one radioimmunoassay a week. So we could only get PSA done sporadically. And I think it's a question of medical systems getting skilled up to do these kind of tests, which ultimately will become quite routine, I think. I accept the challenge that is posed by the average urologist working in a busy peripheral clinic somewhere. We have them all over the world. They can't be expected to do the kind of sophisticated testing currently that is available to some of the centres, not all of the centres, in major developed countries. But I think it will come as these tests become more widely available. And just as now urologists are skilled in the use of PSA, they will become skilled in the use of somatic and germline testing in prostate cancer and potentially in other cancers that urologists have to deal with. So I think it's a matter of time, and urologists need to keep thinking, reading, listening, and learning.
Great. Dr. Tanuja, what do you think of all this? You're a medical oncologist, and I think you probably have been a lot more conversant with doing genetic testing. You send cases for Foundation One and all that stuff.
Yeah, so I completely agree with Prof. Clark. So in the clinic setting is getting a lot. I mean, seeing patients with prostate cancer is getting a lot more complex, and it takes a lot more time. And even even in a tertiary medical center where we have in our center where we are very lucky to have many of these tests available. But there's also the time constraint of counseling the patient appropriately. So in my setting, what I usually do is I tell the patient about, I open up the discussion about genetic testing, introduce them to the idea of the BRCA mutation, and then thereafter I tell them about how this affects their treatment options, their prognosis, and also the ability and how it also affects their family members. And eventually I refer them on to my genetics colleagues, where, because if you sit into the genetics clinic, for each patient they do at least a half an hour to 45-minute counseling session. And I don't think as busy urologists and oncologists we have that ability to do that counseling. I sort of give them an opening and a head start to lead them to see the genetic counselor. Yeah, and moving on from that point, I just see one of the questions on the chat here. Maybe I can direct the question to Prof. Clark. Someone is asking about when would you do the testing? Would you do it only when the patients are castrate resistant, or do you do that as initial diagnosis? What's your practice, Prof. Clark?
Well, we're currently rolling this out, and we're by no means comprehensive in our genomic testing. We've only just set up our familial clinic, and we're focusing on that, and we're getting the tissue into our labs and so on. I think the answer to the question is that when we have it fully functional, we will test them at the start and when they progress. What we know is that somewhere in the region of 5% in a Caucasian type population has a germline BRCA type mutation. And that mutation is different in the somatic setting. As the cancer gets more progressive, then it develops a different type of genotype. And with that comes different phenotypic behavior. So we know that the clonal types then start to emerge with a more aggressive type as the disease becomes more mature, if you will. So we would consider at the outset germline testing. We would look at the primary tumour to see if there was a somatic mutation, but then we would consider rebiopsying certain areas if a disease wasn't behaving as we would like it to behave, to see if there was a specific type of drug in a trial that we could put the patient in. Ultimately, I would hope that this might translate into general practice as more drugs become available and genetic testing becomes more widespread.
In your current practice, what at this moment? I mean, when you see your patients in clinics, so do you test them in the CRPC setting, or and do you do both a tumor testing and germline testing, or do you just do one?
We only do that in a trial setting in castrate resistance when we're recruiting patients into trials, for example, in P10 pathway inhibition, certain types of DDR inhibition, and so on. What we've become much more savvy about is identifying patients early on. In other words, young patients, family history, patients who are presenting with heavy tumour burden as a first presentation. And you saw in one of my slides, in this country, about 16% of the patients present with metastases at first presentation.
Yeah. So similarly for practice in our center here, what I do is for the patients who come in but early on in the CSPC setting, let's say if they were young, they had a very strong family history, then for those patients, I would send them to the genetic counselor for germline testing. But if, let's say, they seem like your regular patients doesn't have any high risk factors, but usually in those cases, I wait till they are in the castrate resistant setting, and then I send them for either tumor testing or somatic tumor testing or germline testing, depending what's available. Because currently in our situation for our patients, they actually have to pay out of pocket for these tests, and it's fairly expensive at this point of time.
Yeah, and I think that's a really important point to make, that these tests are expensive currently. But I go back to my PSA story. When PSA started, it was very expensive and difficult to get done, actually. Now it's very cheap. There is a question about circulating DNA, and I think it's important to perhaps consider that. For those of you who are not initiated in this field, most of the germline testing is done on tissue, and in the trials and in research, there have been big efforts to try to simplify this, because naturally getting tissue from patients is not easy. And so circulating DNA is the DNA fragments released by tumours, which are measurable on a blood sample. And what is getting better now is the correlation between circulating DNA subtypes and what's actually happening in the more aggressive bits of the tumour. So I think this will come, and it may not be in the long term the case that we have to have a piece of tissue from the prostate or from a metastatic site. We potentially will be able to do this on a blood test, and that will be a big advance.
Yeah. And with regards to yourself, Prof. Clark, do you prescribe PARP inhibitors in your setting, or do the oncologists prescribe the PARP inhibitors?
Well, that's a very good question, and it does vary across the world. There's what we would describe as a turf war in some areas. People say, well, it should be oncologists, it should be urologists. My own view is that it should be a specialist who's trained and skilled in the process. We, in the UK, surgeons don't give cytotoxic chemotherapy. That's not allowed, and that is quite appropriate in my view. I wouldn't expect a medical oncologist to do a radical prostatectomy. But giving novel hormone agents, well, why not? Giving PARP inhibitors, well, I would see that a properly trained uro-oncologist, either a surgical or a non-surgical one, should be able to give these drugs, but not the general urologist.
And yourself, do you prescribe the PARP inhibitors for your patients?
It's only available in trial settings at the moment.
Okay.
Right. Just to jump in there, do you think that, and to turn that question around a little bit, do you think that urologists would be able to get comfortable with dispensing PARP inhibitors? Obviously, starting off with somebody who has a primarily uro-oncological practice, seeing metastatic prostate cancer patients, treating them with novel hormonal agents. In your experience, do you think that it is a significantly more challenging drug to give?
Well, every new drug brings with it challenges, and so androgen deprivation is not an easy treatment. It's quite toxic when you look at it, and it's important to understand that. So the knee-jerk reflex, which some urologists has, which is, well, it's prostate cancer, it's advanced, give androgen deprivation straight away. there needs to be more thought about that. And clearly, with a drug such as a PARP inhibitor, which has got side effects, no doubt about it, it's one has to select the patient, one has to be aware of the side effects and so on. If you take enzalutamide as a commonly prescribed drug, that's quite toxic, actually, in so many ways. And anyone prescribing it, whether it's a surgeon or a non-surgeon, needs to understand that.
Yeah. Thanks, Dr. Clark. So I think we have another question from one of our radiation oncologists. I think from Jeffrey. So he's asking, should we concentrate on just BRCA1, BRCA2 ATM mutations, as from cohort A of the PROfound study, or should we look at all the other mutations? What are your thoughts on that?
Well, it's a very important question, a very good question. I didn't concentrate on the details of some of the genomic profiles that I showed in my talk. Currently, the important ones are the BRCA1, 2, particularly BRCA2, CHEK12 ATM, but there are others. And in one of the studies, which we've done with Stampede, is to look at hormone-naive genomic profiling. And that seems to be different to the genomic profile in castrate-resistant disease. So, for example, P10 and alterations in P10 are significantly different. Some of the more primitive pathways, the WNT pathway, which is a stem cell pathway fundamentally. Now, these are potentially important because certainly there are P10 inhibitory drugs coming down the line, and they're in testing, PI3 kinase type drugs. And we may ultimately develop something like a WNT pathway inhibitor that's specific enough to be used in clinical practice. So currently, to simplify that answer, BRCA1, 2, ATM, CHEK12 are the most important, but there will be others.
Just to add to that, Jeffrey, so, from the studies, we know that BRCA1 and BRCA2 are the most important, but from clinical practice itself, I've seen patients with RAD51, PEL-B2, and, mutations that respond to PARP inhibitors as well. And, with our patients living longer, I think just sort of testing and being able to prescribe the patients the drug and sort of giving them a longer runway, I think that sort of makes a difference as well. KJ?
Right. I think, on the back of that, there's a question in the chat, which I thought was interesting, that one of the audience is asking, most data comes from the Caucasian population, and rightly so, because the incidence of prostate cancer is like 10 times that of Asians, at least in our country. I guess one of the questions is the prevalence of HRR mutations in Asians similar to that of non-Asians? So I just wonder what both of you think, Prof. Clark, as an expert in the field, whether you've come across any data that suggests that, and Dr. Tanuja, whether you've seen any of that.
Well, this is fundamentally important because a lot of the literature, the scientific literature in medicine, is based on Western populations. So in my country, for example, if we take a population, it's predominantly white Caucasian. We have about 17% of the population is ethnic, of which 3% is Afro-Caribbean type descent, in other words, the North American black. We have about roughly 5% Asian. So it's not really representative of a population in your part of the world. And we really do need to understand this better. So I would encourage all of your colleagues to get stuck in here and do the research that's needed, because we do need to know whether people of Asian descent in all its forms respond in the way that Caucasians do, and I suspect that they may not. Certainly, if we look at the hormonal studies which were done in Japan and continue to be done in your part of the world, populations of Far Eastern origin seem to respond better to androgens than some of the white population, and particularly the black populations. So these key differences will be very important in the future. We need to find that out.
So from actually, we had KJ, Joanne, our geneticist, had done a study. It was just a small study looking at the prevalence of germline mutations of BRCA1 and BRCA2 in our prostate cancer population. And if I remember correctly, they presented it as a poster in one of the conferences. It was about 10 to 15%. That's for germline BRCA1 and BRCA2 mutations. Yeah, but with regards to the somatic mutations and things like that, I think as we use the drug, and now that we are doing testing more frequently, I think that's something that we can potentially look at.
I found it really.
Well, we look forward to getting that data. That would be really important.
Yes, definitely.
Yeah, I found it really fascinating that that last part of your presentation, Prof. Clark, on Propel, which suggests that people are wanting to apply olaparib and other similar drugs to all comers. And what does that mean for genetic testing? On the one hand, we want to know as much as possible to deliver a good precision medicine. On the other hand, if it turns out that everybody does benefit, does that mean that in the future we might be actually not doing genetic testing for something like olaparib? What do you think of that?
Well, we'll see. We are nervous but optimistic about whether Propel is going to be positive. I don't know if it will. But if it is, it will be a game changer, because coming back to your question about urologists working in communities, not necessarily in academic centres, well, this will be great, because you wouldn't need to think too hard about having your patient genetically tested if there was going to be an across-the-board response. But I would add a rider to that, and that is urologists must not stop thinking. They must always look critically at what they do, because applying a broadly based therapy to everyone is probably not that good an idea. We got lazy in urology over many years. ADT, well, we got a prostate cancer patient, give them ADT. Okay. And everybody stopped thinking. And that, I think, is why we're so far behind breast cancer, actually.
It's a real shame. We hope to correct that.
Yeah.
Yeah.
And on that note, if we're talking about the Propel study, let's say if the Propel study comes out to be positive, and you can prescribe a combination of your novel hormonal agents with your olaparib in patients, they need to be tested. How do you see the treatment paradigm of metastatic prostate cancer changing?
Oh, I think it'll change dramatically if Propel is significantly positive. So remember that the design of Propel is early on in the castrate-resistant pathway. It's not a late thing. So the VISION trial with lutetium is right at the end of the treatment pathway. Patients have had docetaxel, they've had novel hormone agents. This is for patients who are failing, who may have had docetaxel or may not, who have not yet had a novel hormone agent. So it's right at the front of that first-line failure pathway. So if it is strongly positive, it will change the landscape, I think.
So do you see?
Of course, it has to be paid for.
Yeah. So do you see all patients with HSPC getting chemotherapy, and then when they become CRPC, then they do a combination of hormonal agents with olaparib? So you sort of like if that becomes positive, then you sort of think people may not be using the hormonal agents upfront?
Well, that's entirely possible. Entirely possible. And of course, there are trials ongoing in planning and so on, where PARP inhibitors are being put into the hormone naive setting.
And also there are also trials of combinations of PARP inhibitors with immune checkpoint inhibitors as well, right?
Yeah. All of this will unroll ultimately. Yeah, it's quite exciting, actually.
Yeah, and I think I see one question about side effects about the anemia with regards to olaparib, and with what's your experience using olaparib in your trial settings? Do you find that the anemia is a big problem?
Well, anemia is a well-recognized side effect of PARP inhibition, but severe anemia is not that common. And so it needs to be addressed. We see anemia with so many prostate cancer treatments. If you look carefully at the bone marrow profiles of patients on long-term androgen deprivation, and particularly combinations with novel hormone agents, well, they're all marrow suppressed. Treatments like radium-223, lutetium PSMA, which is just starting to come to the fore, they all produce anemia, and it has to be managed. So it is a side effect. We know about it. It's manageable, I think.
Okay. Just to mention, I had a patient who had quite bad anemia with the PARP inhibitors, and thereafter, because he didn't have chemotherapy before, so it's very difficult to give chemotherapy thereafter. Because with the hemoglobin being very low, it's very difficult. Usually we try to aim for a hemoglobin of at least 8 when we give chemotherapy with taxanes, and so if you are trending at 7, it's really quite difficult. But it hasn't been very. I mean, this was 1 or 2 patients that I had this problem with.
But of course, late-stage prostate cancer, where many of these drugs have been given in late stage, the patients tend to be quite anemic anyway. And in the last year of life of these patients, I would think we published on this some time ago, it's probably 10 to 15% will need at least one transfusion. Some will need 2, some will need 3. Yeah.
Yes, agree.
Right, great. So I think this is a great discussion, but I'm afraid our time is coming to an end. So I'm just going to summarize the session, and I'd like to thank Prof. Clark and Dr. Tanuja for being excellent panelists, and also the audience for contributing so many excellent questions. To summarize, I think Prof. Clark has shown very nicely that prostate cancer is highly heterogeneous, both between and within patients. There's also increasing data to show that mortality and response to treatment can be predicted based on metastatic burden, which seems to be a continuous rather than a discrete function, which is what, again, Prof. Clark has shown very nicely. Benefits are being shown with earlier use of chemotherapy and novel hormonal agents, and perhaps other newer agents that are in the pipeline. Precision medicine based on genetic testing is now upon us. The genetic subtype can predict the treatment response. While the currently known responding subtypes are few, as Prof. Clark showed, only 10% of patients tested in the PROFOUND study were eligible to receive olaparib. There is now interest in applying some of these agents to all comers, so we eagerly await the readout of further trials to inform us about this. So on behalf of the audience and everyone attending Urofair, I really like to thank Professor Clark and Dr. Tanuja for being here today, and I wish everyone a very good afternoon and weekend.
Thanks, KJ.
Thank you very much.
Thank you.